Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows what they are doing. The hospital has the equipment. The paperwork is ready. Just sign here. I also believed this until I started counting the patients who went in for routine procedures and came out permanently different, not better, different. A man who walked in with back pain and left unable to walk. A woman who survived open heart surgery but lost 6 months of her life to complications no one warned her could happen. And what no one tells you is this: the older your body is, the harder it fights just to survive an operation. Not the disease, the operation itself. I have been a cardiothoracic surgeon for over 2 decades, and today I'm going to tell you the truth about 5 surgeries that carry serious hidden risks for people over 60. Risks that appear in statistics, that exist in scientific literature, that surgeons know, but that rarely reach the patient with the clarity and honesty they deserve in a 15-minute consultation where the recommendation was already decided before you sat in the chair. This doesn't mean avoiding any and all surgery. Surgery saves lives every day, and I am proud to have been a part of that. It means being an informed patient, asking the hard questions, and understanding that a surgical recommendation is not a verdict. It is the beginning of a conversation. Tell me in the comments now, have you or someone you love ever accepted a surgery without questioning if there was a less invasive alternative? Write it here because the answer will tell me how much this information is still not reaching those who need it most. Before presenting the 5 surgeries, you need to understand what happens inside an older body when it undergoes general anesthesia, because this understanding is what will make you take each surgery on this list with the seriousness they deserve instead of dismissing them as an exaggeration. Think of a new car and a car with 200,000 miles on it. If you subject both to the same stress test, do you expect the same result? Of course not. And yet, for decades, medicine treated the 70-year-old body the same way it treated the 40-year-old body. Same surgical protocols, same recovery expectations, same timelines. This is beginning to change, but not fast enough. When an older body goes under general anesthesia, the heart has to work harder, the lungs take longer to eliminate the anesthetic, the kidneys slow down in processing medications, and the brain, this is what surprises people most, the brain becomes temporarily disoriented in ways that can last weeks or months. Doctors have a name for this: postoperative cognitive dysfunction. And in patients over 70, it happens with a much higher frequency than anyone publicly admits. There is also a medical concept called frailty that needs to be understood before any conversation about surgery in older adults. Frailty is a specific medical term. It means the body's functional reserve has fallen below a critical threshold. Approximately 40% of people over 75 show signs of frailty. That number rises to nearly 60% above 85. The real question isn't whether the person can survive the operation, it's whether they can survive the recovery. And those are two completely different things that most pre-surgical conversations never distinguish with the clarity the patient deserves. Surgery 1. Open heart surgery in frail patients, when the treatment can be more dangerous than the disease. Coronary artery bypass grafting, CABG as we call it, is one of the most common major surgeries performed on older adults in the United States. The idea is simple: your arteries are blocked. We reroute the blood flow, and for the right patient, it works extraordinarily well. But here is what the informational brochure doesn't show. Open heart surgery requires stopping the heart completely. We put you on a bypass machine, a device that does the work of the heart and lungs while we operate. For a physically fit 60-year-old patient, this is manageable with a calculated risk. For a 78-year-old patient with kidney disease, mild diabetes, and some degree of cognitive decline, this bypass machine is a simultaneous attack on every organ in the body at the same time, in an organism that no longer has the functional reserve it had 2 decades earlier. Studies published in the Journal of the American College of Cardiology show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, extended time on a mechanical ventilator. And there is a number that stops people cold. Up to 15% of high risk elderly patients do not survive the first 30 days after this surgery, not from the disease that brought them to the hospital, from the operation that was recommended to treat it. But here is the part that matters most for any American adult over 60 facing this recommendation. In most cases today, there is an alternative. It's called TAVI, transcatheter aortic valve implantation, a catheter-based procedure that never requires stopping the heart or opening the chest. Less dramatic than surgery, but much gentler on a body that needs gentleness, not a battle that will require months of recovery and compromise quality of life, during a period that for many older patients represents a significant fraction of the time they have left. The results of TAVI in high surgical risk patients are solid enough that American Heart Association guidelines already recommend it as the first option for certain patient profiles. Not as a second resort when surgery fails, but as the first choice when the patient's risk profile indicates it. What does this mean in practice for you or someone you love? It means there is a question that can completely change the course of a surgical decision, a question most people never think to ask. The question is simple and direct. Am I a candidate for a less invasive approach? Surgery 2. Aggressive spinal surgery, the operation that promises to end pain and often creates worse problems. Back pain in your 60s and 70s is practically universal. I don't know a single patient over 70 who hasn't mentioned their spine at some point. And the solution offered with increasing frequency is spinal surgery. Fusions, multi-level decompressions, hardware inserted along the spinal column. Some spinal surgeries are absolutely necessary, without any debate. A spinal cord being actively compressed, causing loss of bladder control or paralysis, requires immediate surgical intervention. But elective spinal fusion for chronic back pain in elderly patients, the scientific evidence is genuinely disturbing and rarely presented to the patient with the honesty it deserves. A large study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. And the most common complications were not minor: blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fusion begin to deteriorate because the mechanics of the spine were permanently altered. The data on pain relief simply does not justify this magnitude of risk in most cases of chronic degenerative pain in elderly patients. Studies show that for many elderly patients with degenerative spinal disease, aggressive surgery provides no better long-term pain relief than targeted physical therapy and specific injections. Not better, with dramatically higher risk. The alternative includes structured physical therapy programs lasting at least 12 weeks, image-guided epidural steroid injections, facet nerve blocks, supervised functional rehabilitation programs, and specific lifestyle modifications that reduce the mechanical load on the affected segments. For a significant proportion of elderly patients with chronic back pain, this combination produces quality of life results comparable or superior to fusion, without the surgical risk, without the prolonged recovery, and without the adjacent segment disease that often appears years later. Me conta nos comentários agora. Você já foi informado que cirurgia era sua única opção para dor nas costas? Surgery 3. Major cancer resections, when removing the tumor, can rob the years of life surgery should protect. This is the hardest to discuss because when someone hears the word cancer, the instinct is immediate and powerful. Cut it out, remove it, eliminate it. But what 2 decades in surgery have taught me is that the goal of treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does exactly the opposite. The Whipple procedure for pancreatic cancer is one of the most complex operations in all of medicine. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. In younger, healthier patients, it can be a genuine, documented lifesaver. In an 80-year-old patient with heart disease and reduced kidney function, the surgery can technically be successful. The tumor is removed, and the patient still passes away within weeks from surgical complications. Not the cancer, the operation. This has a clinical name: futile surgery, and it is more common than anyone in medicine wants to publicly admit. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced failure to rescue, meaning a complication occurred that the weakened body simply could not survive. The conversation worth having is an honest and specific discussion about what active surveillance, radiation therapy, or targeted therapy looks like for someone of your age and health profile compared to major surgery. There is a crucial distinction: the difference between surviving the tumor and surviving with quality of life. An 82-year-old patient with slow progressing prostate cancer may have a 10-year life expectancy without any aggressive surgical intervention and die of a cause completely unrelated to the cancer. In this case, surgery wouldn't add years, it could subtract them through the morbidity of recovery and the impact on cognitive and physical function that in a frail organism is often permanent rather than temporary. Surgery 4. Joint replacement in severely ill patients. When timing and preparation matter as much as the surgery itself, hip and knee replacements are among the most successful surgeries ever developed. I state this without reservation. But here is where it gets complicated for older adults. The word elective means the surgery is planned, not an emergency. You have time to think, you have time to prepare, and crucially, you have time to ask if this is the right moment for your specific body. Statistics show that in patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries an elevated risk of perioperative complications. Blood clots are the biggest danger. Deep vein thrombosis can travel to the lungs and become a life-threatening pulmonary embolism. In elderly patients with reduced circulation, this risk is substantially higher. Add postoperative pneumonia, hospital-acquired infections, and the impact of general anesthesia on cognitive function. The question that needs to be asked honestly is whether your body is in the best possible condition right now. Optimizing blood pressure, blood sugar, weight, and cardiovascular health before elective surgery can dramatically reduce complication rates. The difference between operating on a decompensated patient and a patient who went through 12 weeks of preoperative rehabilitation is large enough that some American hospitals now require a formal prehabilitation program before scheduling these operations for high-risk elderly patients. Prehabilitation means strengthening the body before surgery, not after, when the damage is already done, in ways that increase the functional reserve that will determine the speed and quality of recovery. Surgery 5. Emergency abdominal surgery. Why knowing the risks? Before the emergency can save the life of someone you love, you don't choose emergency surgery, it chooses you. An intestinal perforation, a ruptured appendix, internal bleeding. But this is exactly why it belongs on this list. Knowing the risks in advance before the emergency happens changes how families make decisions in those terrifying moments in the hospital hallway when time is running out. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We are talking about 30 to 50% in the most severe cases, not because the surgeons are unskilled, but because an elderly body under sudden trauma is fighting on many fronts simultaneously. The liver, kidneys, heart, and lungs are all hit at once. The inflammatory response can spiral into systemic inflammatory response syndrome, where multiple organs begin to fail in sequence. Studies published in the Journal of the American Geriatric Society documented that adults over 75 undergoing emergency abdominal surgery had a 30-day mortality risk up to 4 times higher than younger adults with the same condition. What you can do with this information has 2 equally important components. The first is not to ignore abdominal symptoms. Persistent pain, bloating, or changes in bowel habits in someone over 60 deserve immediate medical attention, not observation at home for a few more days. Catching problems early means treating them before they become emergencies. The second component is having the conversation with your family now. What are your wishes if emergency surgery is the only option? What quality of life matters to you? How much intervention do you want if the chances of full functional recovery are low? These conversations are one of the most loving acts you can perform for the people who will be in that hallway making impossible decisions in zero time. What every adult over 60 should ask before any major surgery. Whether planned or recommended, there are four questions every patient over 60 should ask. What happens if I don't do this surgery? If the answer is that nothing urgent changes in the next 6 to 12 months, you have time to think, seek a second opinion, and optimize your health. Is there a less invasive alternative? Medicine has changed enormously. Robotic surgery, endoscopic procedures, catheter based interventions, options that didn't exist a decade ago are available today in most major American hospitals. What does recovery realistically look like for someone of my age and health profile? Not for the average patient, for you, with your heart, your kidneys, your current medications, and your home support. What is your personal complication rate for this procedure in patients over 70? Surgeons track this data. They know their numbers. A confident and honest surgeon will tell you. I once had a patient named Gerald, 71 years old, a retired engineer. Three different surgeons recommended open heart surgery for a blocked coronary artery. Gerald wasn't afraid of the surgery, he was afraid of losing himself. He had seen his wife go through major surgery and come out exhausted and never quite the same. When I reviewed his profile, kidney function, frailty score, cognitive baseline, I sat with him for 40 minutes and told him the truth. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehab. For his specific profile, the data showed comparable 5-year results. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photo from the top of a trail in Colorado with his two granddaughters, smiling like he'd won the lottery. Not because the surgery was wrong, but because for the specific Gerald, with his specific profile, the alternative was equally valid and significantly less risky, and no one had presented that alternative before he reached me. This video is not about fear, it's about options. Minimally invasive surgery has transformed what is possible for elderly patients. Beyond surgery itself, optimized medical management is genuinely powerful. The right combination of medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that previously seemed to require a knife. A surgical recommendation is not a verdict, it is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The surgeon holds the scalpel, but you hold the choice. Now, I genuinely want to hear from you. 3 questions to answer in the comments right now. First, of the 5 surgeries we discussed today, open heart, spinal fusion, cancer resection, joint replacement, and emergency abdominal surgery, which one surprised you most in terms of hidden risk? Second, are you going to use the 4 questions I presented? What happens if I don't? Is there a less invasive alternative? What is recovery like for my profile? And what is your personal complication rate in the next conversation you have with a doctor about surgery? Write the commitment here. And third, where are you watching from? City, state, country, and how old are you? Take care of yourself. Ask the hard questions. Request the alternatives. And remember, you are not a passenger in this story. You are the one primarily responsible for your own health. It starts today with the next question you ask your doctor.